it's the part of range that we use all the time. We're always doing stuff up through here. So why would it not be a useful treatment technique or a useful assessment technique? The reason it's not is because people don't look at it in a way that makes it useful for them. So it is a really useful position or part of the range to assess quality of movement in, and you can translate what you find with that into useful treatment techniques. The key is that you go into it really, really slowly and really gently, and you don't take somebody from there and wind them up like that, or you'll have them levitating off the bed and they'll never come back to see you. That is why I'll show you that that's what happens, but I would never ever do that on a patient. And if I see you doing it on or think that you're going to do it on a patient, I'll drop kick you from here to Christmas. Okay? The serious, actually no, Christmas next year. Because you will stir people up if you do that. They won't like it, especially people with subacromial problems. Because you can imagine as you come over and do that rotation through there, if you've got a thick bursa, that's going to hurt like crazy. So you don't do that. You are allowed to do it once on each other if your shoulder is okay, just to get the sense of what happens. So what it does is, if I can come up into there where I've not locked anything off, that won't go any further without scapular movement in internal rotation. So that's what's called the locking position. The head of humerus is locked underneath the coracoacromial arch and it won't go any further. To let it go further, you actually have to take it away from being locked or stuck underneath that arch. Allow it to drift forwards, which is what it wants to do, and then allow it to externally rotate. It comes over the top of that hill, it falls off the other side. That's just bone-on-bone anatomy that's doing that. It's the glenoid, it's the head of the humerus rolling around the edge of the glenoid, but obviously your coracoacromial space comes into it as well. So if I'm going to examine this area, what I'm wanting to do is just to get a feel through a number of different parts of that range of what the quality of movement is like. And I'm not going to roll it, I'm going to come down at different angles through that arc of movement and see what they feel like. So if this isn't how I would examine it, but it's to explain it. The top of that hill is always, on no exceptions, it's always halfway between 90 degrees and full elevation. So it's at 135 degrees. And that top of that hill, if I were to let the shoulder drop right down and there was no gravity, it would get to a point where it will just hang there in neutral rotation. Gravity means that she's going to drop into external rotation. But if I'm just taking the weight of her arm and I roll it there, that's the point where that's in neutral. If I push it that way, it wants to externally rotate. If I roll it this way, it wants to internally rotate. That's not me doing anything with her hand. That's what her shoulder wants to do. So that, she's mobile, so it's not a really obvious big hump, but that's the top of the hump. And if I move up in towards flexion, it will go into external rotation. If I move down towards hand by side, it goes into internal rotation. So what I'm going to be so it's like this, the rim of a wheel. And what I'm going to do is to feel the quality of the movement down towards the centre of the wheel along different spokes. Okay, so we're not going around the rim, we're going on different spokes all the way around. So when I do this on a patient, I'm going to be coming not like this, but I will come down first off to that top of the hump position, just test it a little bit to make sure I'm in the right place, and then take her down to when I first start to feel tissue resistance, match that to where she starts to feel pain, and then move it further depending on whether it's painful or just it's just tissue resistance that's there. We'll go down to the point where I feel that's as far as I want to go, either because it's painful or because I've reached the end of resistance. I will then come back up along the same spoke of the wheel. If you've got somebody with anything subacromial that's painful, if you rotate them when they're down here, that will hurt. So come right away from any position that might squish those subacromial structures. Imagine that the arc of the rim of your wheel is up here. We will track it around the rim of the wheel a little way, so it's now in a bit of external rotation. And if I want to come down along a spoke, I've got to come down along an angle that is at right angles to the direction of her forearm, or if you imagine you had a pin through the epicondyles, we're going in line with the pin. So we're coming down there, not straight Then we'll come back up along the spoke of the wheel. We'll let it come around a little bit further and let it rotate where it wants to go. Keeping the elbow at 90 because that makes it easier. And then we'll come down along that next spoke of the wheel. So you might look at top of the arc and 2 positions above that, and then we'll do the same thing coming down the other way. When you come down into internal rotation, you're going to have to actually control that rotation a little bit because of gravity. So we bring it down away from that, away from right down there, so our sort of secondary arc, rim of the wheel. Bring her down a little bit, taking that into that little bit of internal rotation, and then coming down in that kind of direction along the spoke again. Same thing, we're feeling how far into range I can go, what her pain response is like, all of those things. Come back along the same spoke, take her round that little bit further, internally rotate that little bit until we're nearly down to the frontal plane, and then do the same thing again. So I'll look at top of the wheel, top of the hump, 2 spots above, 2 spots below, and we're just basically testing a range of positions through this functional part, a number of positions through this functional range that is clinically often impaired. This is a very sensitive test to pick up impairments. It tells you absolutely nothing about diagnosis on its own. Okay? So if I do that the way I would do it on a patient, I'm going to put this hand underneath the shoulder, the scapula, so that my thumb is just about on her C7 spinous process and my fingers are resting over the top. And I've got myself relaxed down onto it, into a position where I can lean on my elbow and I can rest my hip against the bed, because that's much better for me. She's only one patient. You've got several thousand to treat in your life. You want to look after yourself. So if I'm up here, I don't have anywhere near the same control of her arm. I'm likely to get the shakes, probably not with an arm as small as this, but if I was treating one of you fellas, I might. And I'm going to be working a lot harder with my back and a lot harder with that arm. So if I can get myself into a position where I can lean on the bed, I'm much better off, and I'm going to have much better feel through this arm. So then I'm going to hold, is that us yet? Nearly. Sorry. Okay, if I've got a small arm like this, that's the position I'll hold it in. So I'm hooking this finger around her medial epicondyle and my fingers and this thumb and my fingers at the back. If her arm is too big for me to do that, then I will hold it up like that. And when I get down through there to get a little bit of a push, I'll slide that hand over there. So that's going to depend entirely on your hand size and your patient's arm size. Are we all right?
Yeah, it's just different language.
Okay. Just making sure I wasn't missing something. Certainly not going to be able to understand that. Okay, so is that thumb all right? So I'm going to start up here. Always start basically from across her chest, taking her back towards that top of the hill, that 135 degrees. Clearly you're not going to do this on a patient who's got 90 degrees of movement. So we're going to go down really slowly until I find where I'm not going to find any resistance at all. Yes, I am. About there I can start to find the start of some tissue resistance. Actually going to change my hand position so I've got a bit better control. And from you tell me if we hurt at all. I'm just going to gradually sneak into that tissue resistance until I have gone as far as I'm prepared to go. Now, I'm not going to push this really hard, but that I would say was a 4+ resistance. I don't need to go further than that. Okay, so I can tell how far into range I've got. I can see where her arm is relative to the plane of the body, and I can then come back along that same arm. Okay, neutral rotation. Structures that we're testing are your superior cuff, your subacromial structures, and the superior capsule, and the superior intra-articular structures. So you shouldn't be dislocating shoulders. If you're dislocating shoulders, you're not doing it correctly. Mind you, I've seen Jeff make them dislocate shoulders, so, but he was trying to prove the point. So then we come around the arc of the rim of the wheel, let it externally rotate a little bit, which it will do automatically. We're then coming down another spoke of that wheel. okay? To the point, there's where her tissue resistance starts. Can you feel that? And then if I go a little bit further, it builds up, it gets to the point where I'm not going to push it harder. I could, but I'm not going to. That's about a grade 4. But she's got a very mobile shoulder, and I'm only demonstrating to you. I don't need to push it further. And then I'll come back up the spoke of the wheel, come around a little bit further, let it rotate, come down again. Till up there's the start of her tissue resistance. It's really subtle, so then we can go further. Am I going a different range of movement and getting a different picture of that tissue resistance on each of those 3 spokes of the wheel? And what you'll find is that on some patients, one will be fine, you get into the next one and it's quite a lot stiffer, and yeah, that's my pain. And that's what you're looking for. If it's the same all the way around, it's not really an issue.